All right, good morning, everyone. I'm Amna Shah. I'm the MLA for Surrey-City Centre and also the Parliamentary Secretary for Mental Health and Addictions. Thank you all for being here today, and I want to begin by acknowledging that we are here on the territory of the Musqueam, the Squamish, and the Tsleil-Waututh peoples. Now, we're joined by some very special guests here today. We have, of course, Premier David Eby. We also have Dr. Daniel Vigo, who's BC's scientific advisor for psychiatry, toxic drugs, and concurrent disorders. We have Brenda Doherty, a mother and an advocate for involuntary care. We have Dr. Rachel Staples, who is also a mother and an advocate for involuntary care. And we have Nancy Fort, the former executive director of Pathways Serious Mental Illness Society. So I would like to thank you all for being here today. Now, without further ado, I would like to invite Premier David Eby to tell us more about why we're here today.
Thanks, Amna. It's good to see all of you here today. Shortly after I was sworn in after the election, I asked Dr. Daniel Vigo for some assistance. I had seen Dr. Vigo speak at UBC around ACT teams. These are teams that are out in the streets supporting people with serious mental health and addiction issues, trying to get them supports, trying to keep them alive, get them into assistance. And he made a very compelling case for the province needing to change course, particularly with regards to the care for people who can't make decisions for themselves because they're so ill. This is something that resonated with me because I agreed with him entirely. I've spent my career in law, defending human rights, fighting for people on the fringes, working on issues of civil liberties, and I have never once believed that letting somebody die in a gutter is protective of their human rights. I met with Dr. Vigo. We had some very good conversations, and I asked him whether he really wanted to work with government because he would be subject to significant scrutiny. His background, his work, that he was taking on an issue where there are very strong feelings on all sides of the issue. There's human tragedy, there is triumph and recovery, and it's an issue that almost everybody has an opinion on, and almost none of them are the same. But I asked him to do this work in a very scientific way, to get data, to understand what was happening in our communities around the synthetic drug problem, the crisis of fentanyl, carfentanil, and all the other synthetic drugs that are poisoning people and killing people in our communities. And he's done that. He and his team have spent an extensive amount of time gathering data, talking with decision makers. The most alarming first finding of his, for me, was that at the front line, in the emergency rooms, physicians had different understandings of what their authorities were under the Mental Health Act, what they could do to help people who came in crisis because of an overdose, what they couldn't do, and that it depended on which hospital you were taken to in an ambulance, what treatment you would receive, whether or not a physician would feel comfortable intervening or whether they would turn the individual back out into the street. And that inconsistency is obviously a serious issue, but it is a catastrophic issue where it is a life and death matter. One of the first pieces of significant work that Dr. Vigo and his team turned out was a guidance for emergency room physicians on people adults attending emergency rooms who had overdosed, who have potentially concurrent mental health issues, and how physicians and nurses can respond, what authorities they have under the Mental Health Act, so that everybody was on the same baseline. Deliberately, the team left a far more sensitive and more complicated and far more debated issue for that first piece of work to be complete before they started on building on it, and that is the issue of a young person, a child, who attends an emergency room with an overdose, or whose parents bring them to an emergency room saying that their child is in crisis because of mental health and addiction or just straight up addiction. This is not an issue where everyone's going to agree. But I hope that we can all agree that we need to do our absolute best to provide frontline treatments and supports to kids if it means that they're not going to have a brain injury and it means they're not going to die of an overdose. I think that everybody agrees on that. For our part, provincially, we've worked hard to build out the voluntary care system. We've got foundry centres. We're opening a whole lot more. We've opened additional beds for youth in every parts of the province. We've got capacity. If you are a young person out there or you're a parent of a young person, that person's having a moment of clarity, needs a bed, we can find you a bed. But I have to say, as a parent, and I had conceptions of how life would be before kids, how we would interact as a family and how things would go. I can tell you, send your kids off to school, you don't know what happens at school. I get the one-word answers from my son about how school was. How was it? It was good. What happened today? My middle daughter's a little bit more forthcoming. I often find out what happened at school through her. But your kid can fall in with the wrong crowd. Your kid can be exposed to something you never imagined at school. And kids are smart. They can hide it for a while. But eventually, as a parent, you find out. And it might be well down the road when your child's struggling with an addiction, including to some of the most toxic substances that are out there. And so, as a parent bringing a child to an emergency room who's in crisis, asking physicians for assistance, I think they deserve a couple of things. They deserve the best possible care for that child. That child deserves every chance to be able to protect their brain and avoid dying of overdose. And ultimately, that child deserves the same treatment no matter where they are in the province. That the response is consistent, that it is high quality, and that it gives that child every opportunity and that family every opportunity to be able to turn the corner. Now, some of this work for myself has involved learning from Dr. Vigo and his team about something that I didn't know existed. It's a medicine called buprenorphine. It's almost like and it is not, but it's almost like a vaccine against overdose for a period of time. It blocks receptors in the brain that are fed on by fentanyl that block the reflex to breathe. It lasts for 30 days, but it can only be administered as a person is detoxing or coming off of drugs. It can't be administered while they're still high, and it requires a period of time in hospital to be able to administer it. But if someone receives that medication, then it provides them with significant protection against brain injury and death due to overdose. And these are the kinds of treatments that can be administered with a brief involuntary stay for a young person that comes in, that not just gives them an opportunity to stabilize in a healthcare environment with their parents and with physicians and social workers in the hospital, and potentially to connect to services in the community, but also gives that physician the opportunity to administer buprenorphine. It's my coach. And save a life. Because once that child's brain is injured, it's injured forever. It doesn't heal. They don't recover. And that life is changed forever. Once a child dies, obviously, it's irreversible. This is a profoundly important issue for our province. We need to move upstream. We see the human wreckage in our communities of the synthetic drugs that are out there that are only getting stronger. We see our firefighters exhausted, responding to overdoses. We need to go upstream to the young people and protect them and avoid them becoming statistics. And that's what we're doing here today. I want to thank Dr. Vigo for his courage. This will not be universally well received. I want to thank these parents who are up here with me, who are championing reform around this issue to ensure that other kids have a chance, that the memory of their children ensures that the province does things differently. The effect of the guidance that Dr. Vigo is issuing to healthcare providers is immediate. Physicians in emergency rooms will now know with clarity and will be able to use their professional judgment about whether a child needs to be admitted to be stabilized and be protected from brain injury. If a child showed up in a diabetic shock, we would not ask that child whether they consent to getting insulin, we would just treat that child. When a child shows up in an overdose, I think it's important when the parents are there, when they're saying, please help save my child's life, and we have a medication that can save that child's life, that we administer that medication to that child. This is not the solution. This is not the answer to the entire problem. This is one more tool that with treatment, supports in the community, interventions at school, can help change a child's life and set them back on the right course. But we need to use every tool possible. And I want to thank Dr. Vigo and his team for uncovering this for us and ensuring that we can deliver it. With that, I'll pass it back to Amna.
Thank you, Premier Eby. Now, we know that there are some situations when a young person is in crisis due to mental health and substance abuse. And this can be incredibly distressing, not just for the individual, but also for their family and their loved ones and their caregivers who may be very desperate to get the care for the people that they love. And so the guidance that Dr. Vigo released today is a roadmap for these challenging situations, and it will ensure that young people are getting the best care that is there for them to fit their needs in the most safe, in the most dignified, and in the most respectful way possible. So now I'd like to invite Dr. Daniel Vigo, BC's Chief Scientific Advisor for Psychiatry, Toxic Drugs, and Concurrent Disorders, to say a few words. Please.
Thanks, everyone, for being here. I want to especially thank the Premier and the Premier's office for your courage in steering this process. I want to thank the families that are here, the mothers and fathers that are here. This is a very special day for BC children and families, and also for me as a psychiatrist, but mostly as a father. As I prepared these remarks, my mind kept going back to an old painting, a portrait of a physician tending to a very sick child by a Victorian painter called Luke Fildes. Despite it being a dated image, it embodies what a physician does when caring for a very sick child. We stick with the child. We stick with the parents. We don't let go. We try to save the child's life. Hopefully after today, never again in BC, a physician feels that they cannot stick with a child, that they cannot work with the child's family to develop a life-saving therapeutic plan. Never again a physician feels compelled to let go of a very sick child by discharging them with a bus to one of the many locations in our cities where patients disproportionately go to die these days. For a child affected by severe mental disorders, especially if the use of synthetic drugs is part of the clinical picture, such discharge predictably leads to repeat overdoses, acquired brain injury, and death, all of which are, at least in the short term, preventable. During the past 10 years, there were 250,000 overdose episodes in our province that happened to 100,000 people, killing 17,000 British Columbians. Of these overdoses, 13,000 happened to our underage sons and daughters. More than 1,500 kids suffer an overdose for the first time every year. And we have shown that after they do, many of them have horrific outcomes, immediate outcomes. 15% of them have repeated overdose, 7% chance of acquired brain injury, all within the year of the first overdose. And by the way, the risk of acquired brain injury is twice as high as for adults after an overdose. But it is not just severe brain injury and death that we must strive to prevent. Clinically undetectable brain injury can also occur after any overdose, meaning that the burden of brain damage is much broader than what is captured in a patient's medical record. So, when we encounter a very sick child, particularly a child with a mental disorder that includes exposure to synthetic opioids, there is no time to lose. we need to intervene to prevent brain damage and death. How do we intervene? We should always protect the rights of the child and always use the least restrictive intervention possible. In exceptionally severe cases, the least restrictive intervention is admitting and treating the child, even if it is against the wishes, trying to prevent brain injury and death, which is what truly restricts freedom and choice. So how do we do this? If the child has a severe mental disorder, of which substance use disorders are a subtype, with risk to self or others or serious deterioration, we can admit and treat either involuntarily under Section 22 or voluntarily at the request of the parent. That's right. Like any other critical or life-saving medical procedure, we can provide it with parental consent under Section 20, even if the child disagrees. Such an intervention is considered voluntary and requires that the child is under 16 years of age, that a mental disorder can be ascertained, and that it severely interferes with the child's ability to interact with others and the environment or to understand the risks and benefits of the intervention. These are difficult decisions that should only be considered in exceptional cases where benefits clearly outweigh the significant risks and potential harms involved in treating a child against their will. To put it bluntly, we should only do this if the brain or the life of the child is seriously at risk. But if that is the case, then we should not hesitate. And we should always involve the parents or guardians in planning next steps. And it is the next steps that are the key of healing. Though insufficient, we have excellent services for children and youth in BC. And the first step and main goal after a child is admitted under Section 20 or 22 of the Act is to link the family with the team that will provide the follow-up care. We have beds in BC Children's, at Maples, in mental health and substance use units throughout the province, such as Youth Recovery House, Traverse, New Tomorrow, Nechako, and many more. We have foundry centres that are tailored to their needs, all of which stand at the ready to care for children and adolescents. For sure, we need more beds. We need to improve the quality of the beds we have, and we urgently need to fully staff and utilise the existing beds and teams. But despite our insufficient services, there's a lot we can and should do starting today. When a child or adolescent shows up at our door suffering from a severe disorder that impairs their ability to engage in care, we should immediately connect with the child parents or guardians to understand the background and define what the best treatment plan is, never leaving the family out. That can mean referring the child to a bed, but it can also mean just admitting them to the ED or a pediatric unit long enough to adequately diagnose and provide life-saving medications such as, when indicated and in addition to other psychiatric medications, long-acting buprenorphine, the protective effects of which last from 1 to many months. This can be done in a couple of days with evidence-based guidelines, and even quicker with things that have been developed here in BC by our colleagues and researchers. And we can do this with the consent of the parent under Section 20 or involuntarily under Section 8 and 22 of the Act, minimizing the disruption to the child's life and ensuring a robust follow-up strategy is in place. Such short and timely intervention will certainly not cure the child from their addiction, but it may improve the general behavioral syndrome and will for sure provide time for the health team and family to understand the complexity of the clinical picture and develop the best possible healthcare plan, significantly reducing the immediate risk of brain injury and death, even if it is only a few months at a time. To be clear, for any child or adolescent that is treated against their will because of state of mental impairment prevents them from engaging rationally with others, be it due to hyperglycemia, osteomyelitis, concussion with loss of consciousness, psychosis, or post-overdose confusion, for sure the episode will be frightening, potentially traumatic. And in many places in BC, the hospital setting may not be age appropriate or culturally safe, at least in the beginning, while life-saving measures are being taken. This is the health system we have, and it should never be used as an excuse to withhold life-saving measures for those in need. No one would withhold insulin or IV antibiotics because the ED or the provider are not ideally suited to the child, or because the child refuses a needle, or because the follow-up infrastructure is subpar. That would literally be adding insults to injury. The idea that we should discharge a child after an overdose without engaging the family or without initiating evidence-based, long-acting, life-saving medication is only the result of pervasive stigma towards mental disorders, especially if they involve substance use. Frequently, under the guise of concerns for freedom, is an entrenched belief that these are lesser problems and that we should only intervene when the person and the child has chosen whatever the ideal path of recovery looks like for this or that group. Physicians don't do that. We try to save the child's life while we do our best to minimize the negative experience of delivering care, especially if it's unwanted. The potential trauma resulting from such episodes can be treated, whereas brain injury and death cannot. And the basic measures that can be taken in the moment of urgent need have been proven effective months at a time, not only at treating the behavioral syndrome, but also at reducing the risk of brain injury or death. After the child's life has been saved and the brain has been spared, proper healing can begin.
Thank you, Dr. Vigo. I know that working to support some of our most vulnerable populations is difficult, but it's necessary work. And so I thank you for your dedication to this and helping adults and young people with severe and overlapping challenges access the care that fits their needs. Our next speaker understands the challenges family members face when a young person is in need of care but is unable to seek it for themselves. And so I'd like to invite Brenda Doherty to share her story.
My name is Brenda Doherty. I am Stephanie Lawrence's mom. Steph had an addiction to some heavy drugs. She was admitted into a hospital and she was assessed as a mature minor and released without my knowledge of her even being there. And she was given a bus pass. And she left and she died a day later. Had we had something like this in place, it may have helped save her life. Thank you.
Thank you, Brenda, for sharing the unimaginable loss and heartbreak that you've had to go through. And now I'd like to invite Dr. Rachel Staples to speak.
Good morning. Just as a brief background, we are the parents of Elliot Yurchuk, who died of toxic drug poisoning in April 2018. Elliot came to his addiction initially through prescription drugs while waiting for surgery to repair a very badly damaged shoulder injury. So as a mother of a child, of my child Elliot, who we lost from the devastating impacts of mental health and addiction, I know firsthand that families will do anything to keep their children safe. Voluntary care, while essential, isn't enough for youth who are in crisis and unable to make decisions in their own best interest. Today's announcement recognizes that sometimes involuntary care is the only window we have to stabilize a young person, keep them alive, and create the opportunity for real recovery. If this kind of intervention had been available to us as parents, it could have kept and given Elliot the chance he deserved. No parent should have to stand by helplessly while their child slips away. One of the most painful failures of our past system was the way the law allowed Elliot, while clearly impaired by a substance use disorder and severe mental confusion, to make his own medical decisions. He was a child, and a child in crisis, yet we as parents had no legal ability to step in and protect him. The system treated him as capable when he was anything but. This inability to intervene, to parent him in the moments when he needed us most, directly contributed to his death. This is why this guidance matters. This is not about control. This is about giving families a fighting chance to save their children's lives before it's too late. Thank you.
And now I'd like to invite Nancy Ford, who is the past executive director of Pathways Serious Mental Illness, to come and speak. Nancy.
Thank you. I'd like to start off by saying the reason I ended up as the executive director, retired now, of Pathway Serious Mental Illness Society was because my son was in throes of psychosis. He was being followed. There were microphones in his room. There was auditory ongoing hallucinations. And even though we had had a referral to the local mental health team, nothing took place until one day we were in crisis and I phoned Pathways Serious Mental Illness Society and we were given the information and the tools needed to get him into care. So Pathways has educated families for over 25 years, supporting thousands of families dealing with mental illness. Through this work, we have gained insight into anosognosia. It's a neurological condition in which individuals experiencing psychosis cannot recognize they are ill. This lack of insight, often compounded by paranoia and fear, undermines a person's ability to make safe decisions and leaves families unable to intervene before tragedy occurs. Most major decisions in life are made collaboratively with input from professionals and loved ones. Yet when someone is deteriorating into psychosis on a path that too often leads to homelessness, victimization, addiction, or the involvement of the justice system, our system still relies on the judgment of the individual. At this very moment, they are least capable of making informed choices. Here today, we're talking about children. To prevent these predictable and preventable outcomes, BC has adopted coordinated treatment models of care that include clinicians, families, and individuals wherever possible. This approach leads to better stabilization, stronger continuity of care, and dramatically improves long-term outcomes. As a parent of a son who is well, who is part-time employed, living in supported housing, I have seen firsthand what the challenges families face. My son would likely be dead, addicted, or in prison had he been left to navigate his psychosis alone, or his addiction, as in this case. Because of BC's Mental Health Act and FIPA and PIPA, he was hospitalized at a critical moment, stabilized, and was given the chance to recover. Involuntary intervention was not punitive. It was life-saving. This is why my family and many others strongly support the province of British Columbia, Dr. Vigo and Premier Eby in strengthening the Mental Health Act to ensure that involuntary patients receive timely treatment upon arrival at hospital. Early intervention restores judgment, reduces long-term system burdens, and gives families and their loved ones renewed hope. For thousands of families, prompt involuntary treatment is not an abstract policy debate. It is a difference between recovery and irreversible harm. We urge legislators to continue advancing legislation that protects the most vulnerable and supported, coordinated, evidence-informed care. Thank you all, and especially thank you to the mothers who are here and fathers who are here today.
Thank you very much, Nancy. As you've all seen today, we have families here who have shared their stories of their loved ones, stories of heartbreaking loss, unimaginable pain, and also stories of resilience, which is the reason why the work that Dr. Vigo and Premier Eby are doing right now and will continue to do is really a lifeline for families all across our province. So this brings us to the end of this morning's event. Thank you again, Premier Eby, Dr. Vigo, and especially all of the mothers, the fathers, and the families here today. We thank you for sharing your stories with us. And now we will take questions from the media.
Thank you, Parliamentary Secretary Shah. We're going to take some questions from the press now. All members of the media will have one question and one follow-up. For reporters on the line, please remember to press *1 to enter the queue, and remember to unmute yourself when you're called upon. We're going to start here in the room with Pinky Wong from CBC.
Hi, a question from Dr. Vigo first. Can I ask for clarification, is the medication buprenorphine currently used in the system, or is this something new that's going to be distributed across hospitals? And you mentioned that the medication could help young people to be off the drugs for 1 month to up to a few months. Does that mean they're going to be put under involuntary care for that period of time as well? Thank you.
Thank you for the question. The drug buprenorphine is evidence-based. It's been used for a long time as one of the mainstay of treatment for patients who have an opioid dependence. There is a formulation that is a long-acting version, which you give an injection once, and it works for at least a month. And so what that allows is kind of the opposite of having to keep the child. Of course, if the child needs a bed, they will get the bed. But if what's needed is a quick intervention that will minimize disruption to the child's life, the kid can be admitted to the hospital, initiated on buprenorphine, which are various ways, evidence-based ways, in 1 day, 2 days, depending on the way it's done. And then the kid can continue their treatment in the community, either pre-existing treatment or treatment that can be put together in that month, where the likelihood of that kid, even if they use fentanyl again, will suffer brain injury or death is dramatically diminished.
Yeah,
and that is widespread, that the use of that drug is widespread across the system.
Yeah, is that new? Like, is that something new across hospital system? Is that what you're bringing forward today? Is that this medication will be available in hospitals if a child needs it?
No, what's new today is that, what I'm saying is that we can use it with the consent of the parent for a kid who is in the moment suffering a mental disorder that qualifies, meets criteria for Section 1 of the Mental Health Act. Now, as the Premier said, unfortunately, up to now, there were different interpretations of whether one could or could not do that. And many of my colleagues thought, sincerely thought that they couldn't use it at the request of the parent. And now I'm clarifying that yes, we can, and yes, we should, when there's a medical indication for it, which is a kid who has developed a dependence to opioids and is at risk of, death, brain damage. The physician can ascertain the mental disorder. If they're going to treat voluntarily at the request of the parent, because like any other treatment, it's considered voluntary if the parents request it and the kid meets criteria for Section 20. And then it is given once, and the system has a month at least to come up with the right long-term treatment of the addiction, which of course is much more complex. This does not guarantee success in the treatment of the addiction or the mental disorder. It gives us a window to develop the treatment.
Thank you. Another question for Premier Eby. Now we're doing something in the treatment process. Like, what is the government doing in how child can access the drugs in the first place? And after this treatment, what's being done, building their connections within the community, maybe back to jobs and maybe back to school?
Yeah, thanks. Just quickly on this medication. I first heard about it. I was like, well, why isn't there a lineup down the street of people who are struggling with addiction to get this and protect their brains and protect themselves from overdose? The reason is twofold, as I understand it. One is that there needs to be some degree of detox in order for the medication to be fully administered. And the second is that it does impair the high that you get from fentanyl and other drugs, as well as protect your brain and prevent you from overdose. So someone who's really struggling with addiction might struggle to make that decision to protect their brain versus impairing a high down the road. That's how addictive these awful drugs are. The network of supports for kids is crucially important. We've put integrated youth mental health teams into schools, school boards across the province to ensure that kids are supported through the school system. In the community, we have the Foundry Centers that are custom designed to support kids who are struggling, to connect them with training and work opportunities, a place to be, a third place to be other than school and home, where they can access services, and also where they can connect with mental health and addiction services specifically and be supported in the community. We also have, when necessary, when someone is particularly ill, we have ACT teams, which are, Dr. Vigo could speak about this, but they follow people in the community, they check in on them, they make sure that they're getting their medications and they're stable in the community. In addition, we also have youth treatment beds, and we're opening more. Just recently, we opened 10 beds in Surrey. We continue to open additional beds to support kids with what needs to happen when they have this window of clarity, we hope, through this intervention. That is the ability to treat the underlying addiction, to address the issues, and help them stabilize, and for the not just for the short term, but for the long term.
Thank you. We'll head across.
Question for Dr. Vigo.
Okay.
I just have to set up. So if you don't mind stepping up, I have to set up my shot and then run to the mic and ask the question.
Okay.
So thank you very much. One, switch over here. All right. Shelley Moore from CTV News. Just a point of clarification about the drug itself. Does it inhibit or reduce drug-seeking behavior at all?
That depends on the person. It may or it may not. It's a partial agonist, and so people who are dependent on a full opioid agonist may continue to seek those drugs. But what we see is that regardless of whether they keep using fentanyl or not, the likelihood of respiratory depression, which is what produces the anoxia in the brain that kills the neurons, that is significantly diminished. That risk is significantly diminished. So it creates time for us to intervene in the long-term issues that yield to craving, that yield to a person not being able to recover.
Thank you.
Do you have a follow-up, Shelley?
No.
Okay.
Hi, Jennifer Lencher from Squamish. I'll ask Premier Eby first. So being from Squamish, we followed Brenda the 8 years, like since days after her daughter died, pushing for this. And I've sort of seen you, we've asked you before, and you're always empathetic, but a little more hesitant. So what personally has changed for you to come to the point where this clarity is happening?
Thanks. There are two pieces to this for me. One is I committed to British Columbians. I said we would try everything possible to save lives, prevent overdoses, and get people back on track. We have tried a number of things. Some have worked, some have not. We need to be open to different approaches. And that we would follow the evidence. We would, if doctors provided us with information that there was something we weren't doing that we should be doing that could save a life, that we would do it. Around young people, my apprehension came from advocates saying, look, what you're going to do if you involuntarily treat a child in hospital is that if that child overdoses in community, their friends are going to be more reluctant to call an ambulance. They're going to be more reluctant to call for help because they understand that that might result in the child being detained. And that is a powerful argument. We want people to call for help. We want people to go to hospital when they're in crisis. But Dr. Vigo's research makes it very clear that if we are able to intervene in that moment, we can significantly reduce the risk of brain injury and of death for a significant period of time that enables parents, families, and support systems to kick in to help that child. instead of having them overdose again and again and again, including potentially and shockingly without the parents' knowledge. Addressing those components struck me as very crucial. But what I can say is an example of what really drove this home for me was sitting across the table from people like Brenda. Brenda came to my office just down the hall here and spent time with me and shared her story of her daughter and the profound failure of the system. And there is no answer that I could even contemplate that would explain why the system acted the way it did in response to that obvious crisis. It was a catastrophic failure and completely unacceptable. And it gives me, as a person who's charged with the responsibility in the province of setting the policy on this with my colleagues, those horrific stories, as terrible as they are, give us what we need to respond to the reasonable arguments on the other side. To say, look, I understand what you're saying. That is a powerful and important issue that you're raising. But at the end of the day, sending a kid out with a bus pass instead of with a medication that would save their brain and save their lives and letting their parents know, there's just no argument. There is no answer except for that we have to do this. And so I want to thank Rachel, I want to thank Nancy, I want to thank Brenda, I want to thank all of the parents who step up and share these incredibly awful and painful stories, because we need to do better, and this policy change will help us do better, and ensure that that those lives, while they should never have been lost, will not have been lost in vain, and that other children will be protected going forward.
Thank you. Yeah, for Dr. Vigo. So can you walk us, I know you're familiar with Brenda's case, can you walk us through what would happen? So you have a 15-year-old, she's super smart, she's super articulate, she can talk her way out of any emergency room, but she's troubled, her parents say. So what'll be different now if Stephanie, a little Stephanie walks into the emergency room?
Yeah, that's the main question. And it has a clear answer. Up to now, my colleagues had been told that they had to assess a child such as you just described as a mature minor. And that is just not the case. The test for that is very clearly spelled in Section 17 of the Infants Act. The consent by a child is only valid if two very stringent conditions are met. If the physician is satisfied that they were able to explain the risks, the consequence and benefits of the intervention to the child, and that the child has understood it, number one. Number two, that intervention is in the best interest of the child. And so my colleagues had been told and used to think that in that context, they could intervene. What we're saying here clearly is that the physician has to make that careful assessment, and in a case like Stephanie, or in a case like Elliot, they can decide before 16 years old, the first time that such a thing happens, they can decide that that test is not satisfied and that they can treat voluntarily with the consent of the parents. Discuss with the parents and the child the different options and make the decision with the parent, for example, to provide what is a very clear evidence-based treatment for something which is a severe mental disorder. It is one of the most severe mental disorders that exist, opioid use disorder. And it's even, that had been already considered one of the most disabling disorders that we had as humans, and that was before fentanyl. And so such a kid deserves to receive an intervention at the request of the parent that will not cure the person from the addiction, that is much harder and long-term, but creates the conditions for that brain to be protected, for the pediatrician and the psychiatrist and the foundry team to weigh in and define what the best course of action is.
We're going to head to the phone lines now, and we'll start with Fran Yanner from the Northern Beat. Go ahead, Fran.
Thanks for taking my question. The Premier, I'm in Oregon, as you well know, tried to pass legislation to hold youth involuntarily in the hospital following overdose and met with huge backlash from special interest groups. Wondering what's changed since then, and how exactly does this policy deal with what sounds to me like parents' main concern, which is that they are shut out. The system shuts them out once their child is 12. I recall this with Elliot's case. Will the system have to flag the parents if the child comes in for something that isn't an overdose? Like, I think he had a broken bone or something, and they noted it at that time that he had an opioid use and did not tell the parents. Will this change that?
Thanks, Fran. I'll let Dr. Vigo speak to the specifics, but the goal here is that, to my mind, ensuring that physicians understand that they have the ability to contact the parents. And what Dr. Vigo articulated to me was that physicians were under the impression that it was illegal for them to call the parents, that they were violating the law, when in fact the Infants Act and the Mental Health Act make it clear that the parents can and should, the guardian, including the guardian of the child, should be involved. And so that's a crucial piece. I think there have probably been many physicians and nurses across the system that would have loved to have called the parents, to get them involved, to ask for help, to ensure that when the child left the emergency room, that child was safe, but felt like they couldn't do it. So overcoming that hurdle was crucially important. On your first question, bluntly, I don't think a lot has changed on the ground in terms of some of the reaction we may see to today's announcement. I hope it has. You know, as we see the growth in overdoses coming from young people, as overdoses overall trend down, but we see an increase in overdoses among young people, I would hope that that would be a signal to everybody that we're not doing enough, that there's more we can do. I would hope that there's a willingness to engage and understand that this is just one tool. It's not the whole solution, but it creates a window of prevention of brain injury and death that allows those voluntary mechanisms that we're building out in the province to be utilized by family and by kids. But I do expect there to be some critique. I expect there to be critique of Dr. Vigo and his work and who he is and whatever else. But I can tell you, standing in front of these parents here today, that I know we're on the right side here. I know this is the right thing to do. There's just absolutely no question in my mind. And I want to thank those parents for telling their stories and cutting through what can be a very confusing debate for a lot of people and making it so clear that we have to support kids when they're sick. And Dr. B, you want to talk about Sure, Rachel.
So in the past, speaking to your question about Elliot coming into the hospital with another health issue and being diagnosed with an opioid use disorder, in the past, of course, we weren't informed. When he had an overdose and he was brought to the hospital, the only way that the physician felt that we could be informed was sitting by Elliot's bedside as parents. The doctor spoke to Elliot about his opioid use disorder.
That's when I recognized the severity of the problem. We were completely cut adrift. We were handicapped as parents. We were unable to participate in Elliot's care. If Elliot had taken a car out and had a terrible accident, we would have been responsible. And yet he's trapped in very high-risk behavior, and we are completely cut off and given no information nor any tools to care for him. And that, our isolation, our being cut adrift like that, was also the experience of the medical team. We interfaced with the hospital for over a month. Elliot was in care in a hospital for over a month. And the caregivers were completely detached from Elliot and Rachel and I in terms of giving us advice and helping us. And I think it was out of fear that they were in a legal environment that they could be in trouble for sharing with Rachel and I medical information about Elliot, that Elliot at 15 and 16 said, I don't want my parents to have any of this information.
And so this is why we're all here today, is to ensure that parents get that crucial information from the physicians to assist in that proper diagnosis and proper treatment plan in the long term to save other children's lives. And it's painful for us to be here, but we also feel that it's critically important moving forward to make sure that nobody has to experience the heartbreak that we can visibly see.
Two other things I'd like to mention. It's a very unrelatable circumstance, fortunately, for most British Columbians or most people. There's been a comment about getting high and falling in, and I'm not judging any conversation, but in order for others to see how relatable it is, Elliot wasn't a wild partier going downtown every night. Elliot was a very good athlete who'd had 4 surgeries and was delivered to addiction through that treatment process. And please correct me if I'm wrong, most of Elliot's opioid use in the last 3 years of his life was to maintain normalcy, to avoid detox and maintain a normal demeanor. He would go to school with opioids on board, not high, not dancing around, not detached. He was using those drugs to present in a normal fashion. So as parents, you're hopeful. You have faith your son is making good decisions. You have your arms open saying, son, if you need help, we're here. We had the means to help Elliot in any fashion, but he thought he was in control of his illness, and he wasn't. A 16-year-old boy doesn't understand the fragility of life in any match, whether it's on a rugby field, whether it's driving a car too fast, whether it's getting in a fist fight, whether it's sailing in rough water, or using opioids to maintain what they think is normalcy so they can attend school that day. So I hope that helps people relate to how their child can fly under the radar and then die with one bad batch of drugs.
Thank you.
Fran, do you have a follow-up?
I'd still like Dr. Vigo to answer the question, please.
Can you repeat the question, please?
That was if a child has an interaction that's not an emergency overdose, drug use related, but like as in Elliot's case, has an interaction in which the healthcare system discovers opioid use, for instance, is the onus on the healthcare system? Do they have an onus to contact the parents?
Again, this is not necessarily related to the emergency department. In any area of the healthcare system where a physician comes upon a child who is suffering from a mental disorder that is serious enough that it meets criteria, that it meets Section 1 of the Mental Health Act in terms of the impairment in the interactions with the environment and others, the physician can then provide treatment at the request of the parent. So the answer then is yes. In any situation, the physician can provide treatment at the request of the parent with the consent of the parent, unless the physician makes the judgment call that the child has thorough understanding of the pros and cons of the intervention. They have understood that, and that intervention is in the child's best interest. In that case, they can proceed just with the child's consent. If the physician finds that either the intervention is not in the best interest of the child, or that the child does not fully understand the consequences of receiving or not receiving the healthcare, then they need to seek consent from the parents.
Okay, Fran, do you have a follow-up now?
Yeah, so you're saying that a child, let's stick with Elliot, at 15 or 16 could have made the decision, if he was living now, to not receive care, and a physician could say that at 15 or 16 he could be capable of refusing care, for instance, and the parents would not be notified.
Again, in any child or adolescent situation, there is a difference between before 16 years old and after 16 years old. Any healthcare-related intervention can be provided, in general, under 19, when the person is a minor. A physician can provide any intervention at the request of the parent, or with the consent of the parent, rather, if the child does not meet those two very stringent criteria that I just mentioned: the full awareness and understanding of the risks and benefits and consequences, and that the intervention is in their best interest. So that can happen at any age. Now, with respect to admission to a mental health facility, that is regulated by the Mental Health Act. And the Mental Health Act does put a time point there that is relevant at 16. So before 16, the child can be admitted at the request of the parent. After 16, the child cannot be admitted at the request of the parent. So if the child needs admission, the child would need to meet a more stringent threshold, which is the threshold for Section 22 of the Mental Health Act, which adds to the regular criteria of having a mental disorder that it needs to present with risk to self or others and serious mental or physical deterioration. Now, a physician, in a case such as many of the children who are at risk, could make a judgment call that a child requires care to prevent that mental and physical deterioration, and that needs to be provided involuntarily under Section 22, or voluntarily at the request of the parents if the child is under 16. That's also important, or makes it very important, to intervene early.
And that concludes today's event. Thank you very much.
Thanks, Daniel. Appreciate it.